You did that very smoothly, Denise. Thank you.
What did I do?
No, you changed the title so smoothly on the side. Wow.
Okay, we have people joining us. It's noon, so I think we'll go ahead and get started. Okay, good afternoon, everyone. I know people are coming from clinic, but we're going to go ahead and get started and welcome everyone to our second webinar, Community Palliative Care Resources from our Palliative Care and Practice Strategies for Community Management and Referral Insights for Family Physicians webinar series. The series is hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Scher. I'm the Associate Dean of the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best care for patients. So we would like to acknowledge that the University of Alberta, its buildings, labs, and research stations are located primarily on the territory of the Nahio, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, and knowledge systems and cultures of all First Nations, Métis, and Inuit nations. Personally, I'm a colonial settler. I've lived in Alberta since 2009. Originally, I'm from New Brunswick, Nova Scotia, so Micmac territory. And I just wanted to highlight this link. So for anyone who's on the call who hasn't had a chance to see the Canadian Medical Association apology to Indigenous people, this is the link on YouTube. It's excellent and I think really worthwhile to watch. And I know everyone's been engaged in a reflection this week. Next slide. So in terms of just housekeeping for the webinar, if you have any questions about technical difficulties or L3 programs and services, please use the chat feature. But if you have questions for Dr. de Kock and Dr. Burton McLeod in our Q&A afterwards, please use the Q&A feature and upvote any questions that you'd really like to have answered as well, because we can't guarantee the panelists will be able to get to all of the questions. So please highlight those. Following the webinar, everyone who's registered will receive a recording of the webinar and a Pearls for Practice document with resources as well. Those are available on our website. MainPro Plus participants may earn certified credits by completing a linking to learning exercise. And both MOC and MainPro Plus credits can be earned for completing personal development activity using the My Lifelong Learning Plan tool, which is free. So please have a look at this QR code. That also works for your CPSA requirements for your PPIP. And so now I'd like to introduce Dr. Ingrid de Kock. Dr. de Kock will share with us information on how to support our patients with advanced disease in the community and to form a cohesive and collaborative plan with other members of the patient care team to support an expected home death. Dr. de Kock joined the Edmonton Zone Palliative Care Program in 2000 after completing a fellowship in palliative care medicine at the University of Ottawa. Prior to this, she was working in several provinces and territories as a rural GP, surgeon, and anesthetist. As a palliative care physician with the Palliative Care Community Consult team, she provides consulting services to the community acute care hospitals, Edmonton hospices, and long-term care facilities. She has a strong clinical focus and is actively involved in program development projects to enhance care for palliative care patients in the community setting. She's involved in teaching residents, members of other disciplines, and particularly enjoys sharing palliative care expertise with fellow physicians. She recently completed 5 years of service as the Edmonton Zone Section Chief for the Edmonton Zone Palliative Care Physicians, and is a past president of the Canadian Society for Palliative Care Physicians and a past clinical professor for the Division of Palliative Care Medicine at the University of Alberta. So thank you so much, Ingrid, and thank you to everyone attending, and I'll turn it over to you.
Denise and Andrea, I just want to thank you very much for the invitation. This is really special to be able to do some presentation and specifically across the province and to my colleagues and other disciplines. And thank you for that lovely introduction. That was very nice of you. So we're going to get started right away. I thought today we're going to talk about some of the palliative care sources available for keeping a person who wants to stay at home to try and help them stay in their own home in the community. And we're going to talk a little bit about home death. We'll get to that towards the end. All right, so I have no conflict of interest to declare. Those days, well, not that those days were ever there, but anyway, it's not an issue. All right, so what I would like to do then today is, first of all, I'm going to talk with you and we will work together on the most appropriate resources that are available in your community to support a patient who has advanced disease, who is in the community in their own home. And remember, that could include supportive living and facility living as well. But specifically the patient who is in their own residence. And then we are also going to talk about, a home death for a person. Nowadays it's called expected death in the home, EDITH. And so we'll be talking about EDITH. I think as palliative care physicians, we always like to put something in about the definition. And I today am specifically going to talk about the palliative approach to care, just to mention that to you, because that is the approach that is needed to keep somebody at home. And it's a bit, it's palliative care for sure, all the principles, but it is something that can be applied. It's utilizing the principles, and that is based on the whole person, so physical, social, emotional, spiritual aspects of holistic care. And it is to meet the needs of the patient and their families or caregivers at all stages of life-limiting illnesses, not just at the very end of life. So I think that is quite important. A palliative approach can be done at any time that a person has a diagnosis of a life-limiting illness. It can be delivered by any healthcare practitioner. Does not matter what kind of training you have, your role, your work setting. So it is something that each one of us, and really every single physician, should be able to apply a palliative approach to the care of a person. And in all honesty, a palliative approach, I wish so that we could just translate it into the care that physicians and others provide to anybody, even those without a life-limiting illness. It's just good care. It's good practice. It's provided at any stage of a life-limiting illness, really is not bound to any age, setting, or diagnosis. And it is beneficial from early till the time of death. I am going to just launch straight into the different services available, but I do want to caution or just mention that I am focusing on the adult patient today. Pediatric services are available certainly in the province, but I think that would be a whole nother talk. So let's talk about home care first. So home care services in the two large areas, the large suburban rural areas of Edmonton and Calgary, we have palliative home care services available both in the urban and the suburban and rural areas of these two large zones. But the teams do vary across Alberta, and so in other places they might have integrated home care teams with a palliative care resource nurse, or some of the integrated home care staff just have built up excellent experience over the years. Home care is palliative home care and integrated home care for palliative care patients, especially within the specialized palliative home care teams, is a case management registered nurse model of care. The services are delivered by interdisciplinary team members, all with a palliative care focus. And there's always 24-hour on-call nursing support available here in Edmonton. I think in all the zones, there is a specific number that can be found. Now, I have spoken to some of my palliative home care colleagues here in the city, and when they heard I was going to give a talk to you, I think that was a bit fast. A few of them said to me, please, do you mind putting it in a word for them? Because they sometimes really struggle to get back the standing orders that the physicians, we as physicians, have to sign in order for them to be able to take on this patient. You know, this is, I'll show you just now what it contains. Because as long as those are not signed and faxed back to them, they're really, their hands are tied. And they also asked very kindly and gently if you would please make their telephone calls a priority. They are very aware that family physicians and nurse practitioners are super, super busy. But when they call, they really need it. So that is just a little request from our colleagues in home care. Now, these are the kind of forms that that you will get, and these are now specific for the Edmonton zone. I think the other zones have their own forms, but it is very similar. So you will be receiving this via fax machine or electronically, and it has to be, your part has to just be filled out, and then it is sent back. The home care nurses discuss this with the patients while they are in the home. So more forms, as you can see, these are actually the medication orders that they require beforehand. And then one more, the good old Bauer routine. You know, palliative care is poop special. We really focus a lot on that because it can be so very uncomfortable for patients. And so these are things that home care nurses just need. All right, so then there we are, next one. So how do patients obtain home care services? Anybody can phone in on a patient's behalf. It doesn't have to be you or your staff. But, you know, sometimes we can assist patients if they don't have somebody who can do it for them. And these are the numbers. I'm not going to go through each one of them, but these are all central numbers, and it will be on the slides in case you don't already have them for your zone. All right, so we're moving on to hospice. Hospice availability. There are hospice spaces in all of the zones. The two larger zones with the large cities have got over 100 beds each. Some of them are freestanding, some of them are most of them in Edmonton are in long-term care facilities, and they just share the the facility, you know, the pharmacy, the kitchens, and so on. In some of the smaller zones or some of the more rural areas of zones, there are sometimes smaller hospices, but there are also sometimes designated beds within long-term care, and I know even in some hospitals, beds that are designated for palliative care patients. All right, so next slide then. Sorry, now I'm making a big mess here. There we are. Okay. So being from the Edmonton zone, I thought for the physicians and nurse practitioners and others in our zone, I am going to just talk a little bit about my specific team that I work in. In Calgary, there is a very similar team, and across all of the other zones, the team might look a little bit different, but we all do the same work. And so for us here, we cover this whole Edmonton zone. We are a specialized team of physicians, nurse practitioners, and nurse consultants. We provide palliative care consultation. Two things that fall under that: symptom management and hospice assessments. In our zone, we do the hospice assessments. I know in other zones, in Calgary perhaps, some of these hospice assessments are done by home care, palliative home care. And we certainly, my team covers all the community hospitals within the zone as well. So as you can see, it's a pretty large area that we cover. I think, you know, the other rural areas of other zones and Calgary probably drive as much as we do. We once worked out how much our team drives in a year, and it was over 2 times back and forth to the moon. So we're very mobile. We collaborate with the referring physician and nurse practitioner. We do not take consults from home care or from other providers. It is purely physician and nurse practitioners, because we need somebody to do the prescribing, you know, for the patient and to continue with the care. In Calgary, especially, I know that there is a bit more of a shared model. Sometimes the consultants will take on the primary care of the patient as well. But here in our zone, we've decided to do it this way. We work very closely with home care and facility staff, and we stay involved until the patient is, until the symptoms are and other issues are stabilized. I need to just find out, how can I let this little thing at the bottom? Ah, there it's gone. Perfect. We are available. There's a palliative care physician available 24 hours a day to provide support. One thing that we have learned in our zone is that we often do get patients referred to us with chronic pain issues, purely because I think the chronic pain services as such are so overwhelmed. So we have decided that that is outside of our area of expertise, and we will let physicians and nurse practitioners know that. Okay, so we go to where the patient is, to the moon and back twice. When can the community consult teams be of help? Well, any difficult to manage symptoms related to the underlying illness. You know, we could certainly also assist with complex family issues, or when there are conflicts. Sometimes just the second voice in there might be helpful to physicians and nurse practitioners and others that are involved with the patients. We also can assist with complex or complicated goals of care discussions. You know, I saw somebody recently who is very adamant that in his beliefs, he needs to take any opportunity that comes his way to prolong his life. And so this gentleman has advanced colon cancer, quite advanced. He's still walking around, so his PPS is probably 50% at this time. But we sat down and we had a really long conversation. And you know what? In the end, we decided he needs to be at an R1 level, not C1 as was done in Emerge, without even discussing with him. He was so angry. He is at an R1 level of care, and there's a long exclusion clause that we will modify as time goes by. So we can certainly help with those. Complex care and symptom situations that might actually require a referral to a hospice, certainly for our zone. All right, and so how to refer in our area, physician or nurse practitioner referral. As I said, we don't take over the care, and so we need the family physician or the attending nurse practitioner to continue to be the center of the patient or the mainstay of the patient's care team. We have a central access number. It is there. We usually will contact the patient within a day or two, and we usually do a consult within a day or two. All right, so this is now province-wide. There is always 24/7 a day and all year round. There is a palliative care physician on call for each of the zones. And we can be reached either through Rapid, or I know down in Calgary they have the specialist link, or you can get hold of us directly through our local programs. For us here in Edmonton, there's always somebody available, a community consult physician available for community advice over the weekdays. And then on weekends, we share a call with our colleagues from acute care as well. But there's always somebody that you can get a hold of. All right, so a few other interesting resources. I'm sure that most of you have heard or might even have had experience of the ATR program. That was started in Calgary and then expanded here in Edmonton, and I think now it covers most parts of the province, although it is not always as well covered in the rural areas. And this is specifically for palliative patients, who are at home and who wish to stay at home. ATR can be extremely helpful there. It's non-lights and sirens response, so they just quietly arrive. And it is a collaboration between paramedics and the patient's healthcare provider, often home care, sometimes family physician, nurse practitioner, and sometimes it might even involve us. They come with extra medications to the home. So, sometimes when we are still waiting to get subcutaneous medications into the home, for example, they might bridge that by coming in and doing those medications for the patients. It's certainly not a long-term solution, but it is usually for bridging. And they can take a patient to a hospital if that is what the patient might wish at that stage, but also if they feel that it is a situation that is perhaps exceeds what they can do in the home, they will take the patient to acute care. They can also help with things like transferring once a hospital bed arrives in the home. They can help with that transfer. Patients who fall and who can't get up, they're helpful for that as well. And the aim of all of this is to avoid transfer to the busy emergency rooms. Mobile Integrated Health, MIH, is a newer service that you have to pre-book for the patient. It is not an emergency service. They can go in and do IV medications, such as antibiotics and permethrinate, for example. They can also do urgent lab tests, if you order it. Involvement is dependent on how available MIH is. And I am not sure if this MIH service is fully available across all the zones yet, but I do know that in Calgary and in Edmonton, they are available. One can reach them. The web address is there, but you can also look at the Alberta referral directory and you can ask for their involvement through that. Now, thoracentesis, or if a patient needs a chest pleurix, this, I think, is one of Alberta's best kept secrets, is the Alberta Thoracic Oncology Program, or ATOP, as we usually just call it. There is a center in Calgary and a center here in Edmonton. The referral details, again, available if you just Google ATOP. I'm not sure, I have to be very honest, what the process is in the other zones. But here in the Edmonton zone, family physicians, nurse practitioners can refer it's very easy and simple to refer to ATOP. And they are very good. They come back usually back to the patient very, very quickly. And there isn't usually a long wait for the patient to get in. And they certainly can then insert chest tubes, chest pleurixes especially, and the patient goes home with those. And home care can help with the drainage on those. Home care and sometimes even the family. So, since I don't know what the process is in the other zones, I thought I'm going to pull my Ask the Audience card. What happens in your zones when a person needs a pleurix drain, a chest drain?
Okay, so if anybody knows, just put your hand up in the participants, and I think we can have you speak up, Andrea. So I'm not sure, Ingrid, if we've got, I'm just looking here. So Fazia is sharing, send to the emergency room as palliative home care can't do it. Fazia, which zone are you in? Chats. And then Mary, she says her microphone's not working. Oh, Fazia, I was just asking which zone you're in. And Mary Abbotsfeld was just chiming in that in Cold Lake, it's the same, that they have to send to the emergency department. And Fazia is in Calgary Northeast. Rob Halsey is saying in Ponoka, we get an urgent interventional radiologist to insert the pleurix.
I was just wondering though, guys, yeah, I can understand. So you would send them into ER or directly to interventional radiologists to insert, and then they go home and you guys, or not you guys, but in your zone, home care can drain, isn't it?
It's interesting to me that Ingrid Fauzi is saying she's in Calgary Northeast and is saying that palliative home care can't do it. So that's interesting.
That is very interesting. Fauzia, perhaps, yeah, we need to have a little bit of conversation, because I think here in Edmonton zone, you say they can take care of it, but not insert. Yes, absolutely. No, the same here. I think that home care, palliative home care, and sometimes we even teach the families how to do it. So I think that is probably across the province available. All right, now.
Mary is trying to chime on, but she can't turn the mic on. Andrea, do you know how to do that? Let me just have a look here.
I will try.
See if you can turn it on. Mary, we're in uncharted territory, so let's see if we can figure out how to get the audio on for attendees.
Do you mind in the meantime? I am going to carry on, but we can always come back.
Yeah, that sounds great.
Okay.
And I'm just keeping an eye on the chat.
Wonderful, thank you. Well, now I think the other part is also compounding pharmacies. I know that is a difficulty in many of the zones. In several of the other zones, it is just not readily available. I think I should say we are lucky here in Edmonton that we have 2 compounding pharmacies, CareRx and Right Choice. And where this becomes important is when you need subcutaneous medications. Nowadays, it used to be that many pharmacies had the equipment to do it, but several years ago the rules changed, and so now they have to have very specialized hoods that they need to use for sterilized products. And here in Edmonton, we've only got the 2. And, it's not as if though you can phone them and say, look, I need Haldol, and they will have it to you in 2 hours. It usually does take a day. Well, if you phone in by 3, you might at least have a few doses available for the nighttime for the patients. And I'm wondering, I have no idea what happens in the other zones. I really could not find out exactly what everybody else does. What do you do when you need subcutaneous medications? Do some of you still have those medication kits, portable ones?
If they raise their hand, I can unmute them. So if someone wants to say something, I think Mary would want to say something. So Mary, I'm gonna unmute you.
Hello.
Hi, Mary.
Hi. So yeah, I'm with Cold Lake First Nations. And so working on a First Nation, we have a little bit of a different scenario. And we struggled with our palliative patients being able to support them to die at home. And sorry, you're having difficulty hearing me?
Sorry, Mary, we can hear you, but it's very echoey on my end anyway.
Oh, okay. Sorry about that. Is that any better?
No, it's not your fault.
Oh, okay. Yeah, so we have partnered with Alberta Health Services to get support to our patients, but it's been a struggle and we're still working on it. So other First Nations may find that they struggle as well because there's that disconnect between what's federal land and what's provincial, and getting that covered. But having said that, when you're asking about some of these supports, we've gotten a little bit creative. And for example, we have a pump that we can do home infusions for patients. So we got that through our local community fundraising for healthcare. They paid for that, and we also got a hospital bed. So those types of things can be done, but it's difficult to connect with the services that are available and how different it is to what's available to a First Nation member versus what's available to the rest of Alberta.
Mary, as much as we would all like to see equity across all the zones and all areas of each zone and all the different sites, it is not a reality. I mean, in all honesty, it is not a reality. But if we can help at all from this end, we're more than happy to try and see what we can do for you guys. All right, I think let's go on. We've still got a few things to cover. So Palliative Blue Cross, this is a really helpful thing for patients because Palliative Blue Cross, even for seniors, has better benefits than Seniors Blue Cross. And so I would encourage everyone who has a palliative care patient on their roster to apply for palliative coverage for patients. It can be retroactive for a month, so the sooner one can do it, the better. The drug benefit list tells you exactly whether drugs are covered or not. Something like Pepcid, famotidine, the injectable one, that is, for example, not covered under Palliative Blue Cross. But, the best way is to go into this website and just have a look and search for the drug. It's really quite user-friendly. For the Edmonton zone, I'm just putting in, again, a plug for, really just talking about it. finding palliative people, family physicians and nurse practitioners who have the capacity to take on palliative care, perhaps capacity and interest and comfort, has been very difficult for us in the Edmonton zone. And I know that in some of the other zones, I've heard over the years that it has been difficult. We are very lucky that one of our new hospices, a freestanding hospice that used to be private and is now part of AHS, their group of primary palliative care physicians have started a home visiting hub. And this has been absolutely wonderful. It has helped us a lot. However, it's a small group, and already their wait lists are starting to be around 3-4 weeks as well. But that might be something in each of your zones. I think you probably have some physicians and nurse practitioners who do that and keep a list. All right, so then a few other just loose tips that I wanted to give you. GCD verbal orders, home care can only accept those if it's an urgent situation. So where the patient might have to go to ER or go to hospice immediately or the next day. In those situations, they can take the verbal order from you. For tissue donation, patient and family log into the Comprehensive Tissue Center. You will get the slides, so that is at the bottom, the link. I think across the province, there are pretty zone-specific tips on where and how to arrange for paracentesis and blood transfusion for somebody who is in the community. And we're always happy to talk with anybody who needs some information. Home collection is available for laboratory investigations. You just have to fax your requisition form to DynaLife and ask for a home collection specifically. This was another tip that palliative home care mentioned to me, that on occasion they've had to drive to a physician's office or home to deliver a blank death certificate. And so I think it makes sense. I now have a whole pack here that I got from Pilgrim's Hospice, because on occasion a patient dies after hours or on the weekend and they need the certificate of death. I've put the link in there to order from the government if you don't already have those in your office. All right, and I can't have a presentation and not mention the usefulness of the Edmonton Symptom Assessment System. These are some of the most prevalent symptoms that we encounter in patients with life-limiting illnesses, both cancer and non-cancer patients. This can be used for all of them. Has been validated over and over, and it was even revised, again validated. Very useful, because if we can all speak the same language and remember to focus on the same symptoms, it makes our conversation so much easier as well. So this is available again on the internet. And then the palliative performance scale, widely used by palliative home care especially, and by all of our teams. And I think that in the other zones, you probably use either this or one of the other performance tools. This is a useful one, though, because just today I was in on hospice rounds, and it helped so much when they were talking about a patient, and to say that, last week, I'd heard that last week the patient was at a PPS of 40%, and then today the patient is at a PPS of 20%. That's quite a drop. So, we had a really good conversation about what has changed so rapidly in a week. But using this can be quite useful to enhance our conversations with each other. Just a few very quick pointers, useful material. I'm not going into details here. Conversations Matter, a great website, really, really helpful website. So that is there. I just put in a green sleeve. We all, GCD, and goes in the green sleeve that goes on the fridge. That is a very useful guidance tool for us as healthcare professionals. This is another very interesting and useful website, both for healthcare professionals, but also I've looked at the patient portal and was really impressed. Again, this will be in the slides, so if you do want to pass it on to somebody or look at it yourself, with all the free time you have, you're going to be reading Palliative Care, I know. And then I have to thank my friend and colleague, Dr. Sarah Burton McLeod, who sent me this lovely slide with lots of links on there. So this is in your, will be in the slides as well. And I just added virtual hospice, useful resource out of Winnipeg. So for you guys to look at. Again, I'm not going to go through all of this, but I think, you know, this gives you a lot more pointers how to, where to direct families who have children who might need some help, and adults who have got some questions and need support. Don't take life so seriously. It's not going to, like you're going to get out of it alive. So we're going to switch course a tiny little bit and for a few minutes just talk about dying at home and what that might look like. Now, question is it even possible? Well, it is very much based on a strong desire for a home death by patient and family. They really have to be committed to it. It needs the support of a family physician and preferably more than one caregiver in the home. And that is work that was done here many years ago, but it still holds true. And it is also very much dependent on the availability and intensity, terrible word, of home care services, just how much home care is available. So dying at home nowadays, I mean, a person can die at home without being part of the expected death in the home program or process, but it does mean, you know, if you die at home and you are not part of it, you haven't been prepared for expected death in the home with all the forms and all the requirements for it, it might mean that, you know, if EMS comes to the home, you call, the family calls 911, EMS comes to the home, they can't sign death certificates, so they might have to get other people involved. So it's certainly, this has made it much easier in terms of the legalities of dying at home. This is based on the palliative and end-of-life care framework that came out in 2014. And so there are now these guidelines for home care staff. EDIF can only be done if home care is involved. We currently have a patient who is from out of country, so home care in our zone cannot be involved in that situation, and that person cannot go through the EDIF guideline process, so will end up, you know, at the end of life having to call, the family will have to call the EMS to come out. And this does need to be in place to obviate the need for pronouncement in the home as well. So that's part of the EDIF process, that home care nurses do no longer have to pronounce a patient. So this is what the form, the first part of it looks like, just so that you know this, the nurses will fax this through to you. And if it comes through, you know what it's about. So to be able for somebody to have a good death at home, they have to be able and able family members who are able-bodied as well at home, and they have to be available 24 hours a day. Family that works and cannot be at home during the day, that person, it just is not going to make for a good home death. Preferably 2 people needed for the care. The physical care can be quite difficult, but also for the emotional support. Patient and family have to be well educated, and this is again where home care plays an absolutely crucial role. But as physicians and nurse practitioners, we certainly are part of that as well. I think one of the perhaps difficulties I sometimes see for families is, that it's undetermined how long the dying process will last. Are we looking at days? Are we looking at weeks? Are we looking at hours? Because people do get tired of the caregiving. It can be very heavy. And there are often symptoms present at the end of life, and these have to be meticulously addressed. This shortness of breath, delirium, and constipation. And then for a person who will die in the home, it is important to be really proactive, change them to subcutaneous medications even before they start having swallowing difficulty. And again, their home care are the eyes and ears for family physicians and for nurse practitioners, and will be able to give you a little bit of an alert. Make sure that things like scopolamine and glycol are in the home for the very end of life, when they have noisy respirations. It's useful to already have it in the home. And the same with haloperidol, have it in the home. Midazolam, if there's any risk that a patient might bleed out. And those things have to be thought through and talked about earlier on. Usually by the time they happen, a crisis is never a good thing. And then usually the families are in panic mode as well. The family physician or nurse practitioner, attending nurse practitioner's role is at least as important as home care's role. There has to be 24-hour availability, or if you share call with somebody in your clinic, make sure that the on-call physician is aware of this patient who is approaching death. One does have to set aside enough time for preparation and planning. Home care will make sure that there are care support workers available to assist the family with the care in the home, at least come in a few times a day at the minimum. And then home care will do a very good assessment and will do the coordinator for Edith. Important to have a home care case manager in place, and they give out a 24-hour contact number, which for families, I think, is a really good lifeline. And then the other really important part is the communication that happens and needs to happen within the whole team, including the patient and family. The process after death, home care, if it is Edith, home care is the first contact. They will contact the family physician or nurse practitioner. They are very lovely and kind. They will usually wait till the next day. Very rarely will they phone at 3 o'clock in the morning to let you know that your patient has passed away. If Edith process is in place, no need for them to go out in the middle of the night and pronounce the body. They don't have to pronounce the body at all. The family will contact the funeral home who will come and collect the body. Sorry, there's a home missing there. And if there is a tissue donation, that needs to be planned beforehand. And then after death, the family calls the Comprehensive Tissue Center. And by that time, they've made all the arrangements and they know exactly how to go about it. And then the death certificate has to be filled out within 24, at the most 48 hours, which can be a problem over a long weekend, for example. And that concludes this part of the palliative care sessions. So please ask questions. Sarah and I are very available to answer them.
Thank you so much, both. I think Aurora had put a question in the Q&A earlier on around who can we call for Edith's support in Edmonton. I think Aurora, I think perhaps your question has been covered, but just as a little recap, for patients, Ingrid, that have been perhaps on palliative for a long time. So I'm thinking of a patient of mine who's on home oxygen and has metastatic breast cancer, but has been on palliative service for like 18 months now, I think, doing quite well actually. How does that process happen? Like, is that part of the discussion that the home care team's having with family, or how does that happen?
Yes, it is. It is initiated by home care. It is. How can one say? It's also almost, let's call it a home care intervention. So it has to be, initiated. You can initiate it, but home care will need to do all the details, fill out the forms, sit with the families, and work through the forms so that they are very well informed of how the process works. So I hope that answers the question.
Perfect. And I think, just to remind everyone, please use the Q&A. I know there's some questions popping into the chat too, but I'm going to keep an eye on the Q&A. So Victoria has a question in the chat, which is, do vendors come to complete in-home care for palliative medical needs, or is it all family? So do you staff nursing care around the clock in the home? I think the answer to that is no, but can you talk about what supports there are for families to get additional supports if they want to stay home?
Yeah, Victoria, thank you. That's a really good question. I think that nowadays, with the current funding models that we have for home care, even with vendors sending in care support workers, it's very limited. What I mostly encounter is perhaps a home care or a vendor sending in support 4 times a day. So it certainly isn't a lot any longer. There used to be a time when we could have a little bit more, even sometimes overnight care, but I think that is now the absolute exception. We might be able to obtain that for bridging. So patient is waiting to go into hospice and we know it's going to be a day or 2. Then on occasion, I see that home care is able to get permission to do that. But it is unfortunately on the family. And so you need an able family and a family with understanding and a family who can do it.
Mm-hmm. Yeah, thanks, Ingrid. Hilda has, actually, I'll just chime in there. There are some services like Nurse Next Door and things like that.
Yes.
They're pricey, but those are options if families have means.
Yeah.
You can hire a little bit for bridging as well, right?
Mm-hmm.
Oftentimes that, they have different kinds of things that they actually have nursing services, but they also have, care workers and stuff like that. It can at least help with some of the heavier nursing needs.
And another thing though, and just one more comment for Victoria, palliative care patients are eligible for invoicing or for a self-managed care. But, I realize that those are an extra burden on the families, but sometimes they work very well. So that might be an option.
Mm-hmm. I think,
and then that is covered through AHS.
It'd be tricky to set up self-managed home care at the end. Basically, what has to happen is that one of the family members has to go and do a course and set up all of the logistics, because basically they're hiring their own care workers. It's pretty doable, and it depends on how many hours that the person is approved for in terms of what coverage the family will get. But then families can top up additional hours of support.
Denise, I see it as really working out well in some of the non-cancer patients with diagnosis. For example, ALS or some of the other neurological diseases. It's great for that. For dementia too, I do come across that. Not as frequently as one would think. Again, I think it is kept a little bit quiet, the whole idea of self-managed care.
Mm-hmm. Yeah, it works very well in certain cases.
Yeah.
People have to hire their own care workers. There is a service in Edmonton called WRAP, W-R-A-P, which will help people with financial recording, because basically they're hiring these people, so with all the paperwork. And they will also help with interviewing and finding care workers. which is another service that they offer, which is helpful.
And that is for the self-managed care. I heard from home care that for the invoicing, they actually manage that part of things. So the patients, the families pay, and then the invoices are sent in. Denise, that is what I heard from one of the palliative home care nurses.
Yeah, it's definitely an option for people if people have the ability to do that at home. So Hilda has a question here. At what point, maybe using the palliative performance scale, should there be a 24-hour two 24/7 caregivers in the home with the patient?
Sarah, and please jump in with me here. But, usually we see that when it comes to the point where the patient is at high risk for falls, and they can't be left alone at home, or certainly when they are becoming bedbound, that is a time that they need family at home, 24 hours a day. Sarah, anything to add to that?
Oh, I agree with you, Ingrid, and it does depend, I think, on the situation overall and also on the trajectory. If things are changing really rapidly, you might want to start thinking about it sooner, obviously. But in general, I think for us, someone who's spending most of their time in the bed or in a chair around PPS of 40, it's kind of a time where if it hasn't been on your radar, maybe give it a think around that.
Okay, guys, more questions? There's a feedback form up, but no, this is great, guys. I think, I guess I have a couple questions. I've been noticing that patients who are palliative with oxygen requirements in the home, or have an end-stage medical illness where it's not going to be getting better, they're required to do blood gases to continue with their oxygen, which seems like exactly opposite to the spirit of palliative care. Could you comment on that and whether there's any movement to change that?
Denise, it's for us, it's actually a step back, because there used to be a time when for palliative patients we could forego the blood gases. I think if a person is truly termed or deemed to be now in a palliative care situation at the very end of life, usually the RTs can go in and we don't need the blood gases. But for people earlier in life who might have a life-limiting illness, yes, it's still the blood gas. And we are trying to work on it, but as I say, it's a step back, and having to take a step back is always makes it harder to move forward again.
Yeah. Okay, folks, chime in if you've got additional questions. I have a question around, so this is interesting to me around the EDITH, because with patients that are moving into palliative care, when you're their primary care physician, you fill in all the forms, and the forms say, you're available for calls and whatnot. And you might be part of a call group and whatnot for if you're traveling or something. But it seems with this whole EDITH, if these patients are not, perhaps they live alone and they don't have a ton of support and they're getting into that phase, is palliative care in the community pretty proactive about then getting them into a hospice bed if they don't have family members? Like, how does that all work, and how does that get sort of activated without ideally emergency visits?
Okay, Denise, no, that's a great question. And again, Sarah, please jump in with me. Denise, I think the beauty of having home care, whether it's integrated or palliative home care in the home, as you know, is that they act as our ears and eyes, and they are very good at letting the family physicians know that the patient is not coping at home, or the family is not coping at home, and to request a hospice assessment. Now, the system or the process of getting patients admitted to hospice does vary from zone to zone. Here in the Edmonton zone, it still mostly works through the community consult team. So my team, we will go out, nurse or physician or nurse practitioner, and we will do the assessment get them into the system. We have to enter them into pathway, and then they are triaged by the bed hub and admitted to if they can wait, they are admitted to the hospice of their choice. And if it becomes urgent, then we get permission to admit them to the first available bed in hospice or room in a hospice. I know that for example, in the Calgary zone, they have, their team is set up differently. So palliative home care works with some of the the palliative care physicians in the program. And so they do the assessments, in conjunction with discussing it with the palliative care physician over time. So they can admit directly. We are starting a little bit of that process here in Edmonton, but we're still feeling it out because we are a little bit worried that, it's a complex thing. We don't want to send patients to hospice too soon, because then after 3 months, we have to make arrangements, if they stabilize, to transfer them. And that is so traumatic for everybody involved. You're going from this high level of care, private room, to now having to go where you need to share a room. And it's a hardship for all of them. But with limited beds, we don't have much of a choice. So we try and get it right from the beginning. So definitely we do try and assess it well. But we can get patients admitted to hospice. Sometimes families realize as death comes nearer that they just can't do it. They just can't cope, even though they all were very committed and are very committed. And it's the patient's wish. But in those situations, we often have to help them accept that it is not a failure on their part. It is a very difficult thing sometimes to care for somebody at home until they die. And we then, work with them, and sorry, let me just get that off. And we then arrange for them to be admitted.
Mm-hmm.
Sarah, anything else to add to that? Sorry, Denise, let me just ask my colleague there.
I agree totally, Ingrid. I think that, oftentimes patients and families would prefer the notion to be home and for the patient to pass away at home, but it just, from a safety perspective sometimes, or practically speaking, it just isn't feasible for everybody. And I think home as long as possible is also a good outcome, and trying to support them around that, and then, be as mobile and flexible as we can. I know a lot of times patients will end up in acute care, which is sort of where I practice clinically as opposed to community these days, but we'll take that as an opportunity to have some of these conversations and be as proactive as possible whilst they're there, in terms of planning and some of the practicalities to try and support everybody if we can.
Yes, and it will take 20 seconds. I see that Mary posted something here, which I think is really a nice way to end this conversation. She wanted to chime in to let people know that there are possible solutions in partnership if we look at them, and equity in healthcare is possible if we work at it. Mm-hmm. Nicely said. Thanks, Mary.
Yeah, no, wonderful. That's a great point to leave at. I think we've actually lost her back to clinic, but maybe she'll see the recording. Listen, well, thank you both so much. This has just been tremendous, and I think so much value for everybody to learn from you guys and just to have conversations. So we will submit the Pearls document to everybody and get the recording out to everybody who registered. And thank you both so much for taking time. And to everybody who participated as well live, that's fantastic. Please do fill in the eval, because we do read them and try constantly to refine what we're doing to better meet the needs of the people who are benefiting from the offerings. So please take a sec to do the evaluations as well. And thank you, Ingrid. Lovely to see you after such a lengthy period of time.
Yeah, Denise, and thank you. In these kind of sessions, we always learn from you guys as well. I mean, I learned a lot today, so thank you all for that, and thank you. And I think Sarah and I are both available via email. We just have Alberta Health Services emails. Certainly are open to answering questions if we can. We don't always know the answers, but we try.
Awesome. Well, lovely. Okay. Thank you both so much.
Thanks a lot.
And thanks, Sarah, for being here this week as well.
Bye.
Take care.
Ciao.